Welcome to another episode of the NEI podcast. It's day one of NEI Synapse, and we are here with Dr. Robb for an extended Q&A session. Let's listen in as she addresses your unanswered questions from today's presentation.
Hi, this is Dr. Adelaide Robb, and we just wrapped up a morning session along with Dr. Cutler about the latest in formulations for ADHD medications and Little Boy Blue treating pediatric mood disorder. So I wanted to answer some additional questions that came up from the audience. Even though we ended early, we still had questions waiting, and I wanted to just expand my thoughts. One of the first questions that came up was, could we comment on E29 for ADHD? So that's the transcranial nerve stimulator. There's a paper that just came out and an editorial in the May edition of the Journal of the American Academy of Child and Adolescent Psychiatry. And Jim McGuff from California was one of the lead authors, looking at a small FDA device registration trial for the treatment with either active or sham E29 in the treatment of pediatric ADHD in 6 to 12-year-olds. They saw in that study that the device was superior to the sham treatment in the control of ADHD, which was delivered while the kids slept. If you want more details, you can look at the article, which again is Jim McDuff, and it came out in the May edition of the JCAP journal. Next question is, was the dosing for venlafaxine and Tordia higher than the FDA trials at 37.5 and 75 milligrams? The answer is yes, that the dosing on venlafaxine was as high as 225 milligrams. And if you wanted to look at the study that was referenced in the slide, and it gives you the mean dose of venlafaxine as well as the maximum dose used. Question number 3. I worry about lithium and long-term consequences of kidney issues. I think anytime we use medication, both in short-term and long-term, we should be following functioning in the organs that are involved. So for lithium, that's primarily thyroid and renal, in addition to some skin issues like increasing acne. In the pediatric registration trials from COLT and also from TEAM, there were no big changes in renal function, either in BUN or creatinine clearance. However, I think we should always monitor for renal functioning over time. Question number 4 said, in the bipolar response slide, there was a 42% oxcarb response in the Geller study. Why not use trileptal? Please comment. It wasn't mentioned much in your talk. In the large placebo-controlled trial done by Kieran Wagner of oxcarb versus placebo, first of all, there was a high rate of nausea and ataxia or dizziness on oxcarb, and it did not separate from placebo in the registration trial, so it's not FDA approved. The other thing to remember specifically with oxcarb, besides those initial side effects, is you can have hyponatremia, and that can be problematic in certain patient groups and can put people at higher risk of seizures. Question number 5, can you speak to insurance coverage and how to get around that barrier? As a child psychiatrist, we fight this almost every day, whether I'm talking about a new stimulant or I'm trying to get somebody approved to take lamotrigine or many of the antipsychotics. I have a couple of sort of pat letters that I've developed over time talking about the child's diagnosis, that it's been well studied, that it's been FDA approved, and we've tried the insurance company's treatment of choice, and the patient has not responded. So sometimes I do have to go through the first tier treatment first, show a treatment failure or non-response, and then ask them to pay for what I wanted. More recently in our large practice at Children's, we also have hired a nurse who is becoming our expert at getting pre-authorizations, and that's taken some of that burden and barrier off the docs, and we use our nurse to help with that. The next question is, what is my clinical experience with lamotrigine monotherapy in bipolar disorder in adolescents? I would say that for most of my kids, lamotrigine is an add-on medication rather than monotherapy. I have been able to take some people off of antipsychotics, though, and maintain them on lamotrigine. The most important thing about using it in monotherapy is to remember you have to titrate very slowly. So if you need symptoms under good control quickly, you may not be able to do that. Next question, what is the percentage of tardive dyskinesia in children on atypical antipsychotics? There have been a few very sort of small studies looking at that. In all of the registration trials for children and teens on antipsychotics, we do collect prospectively information on movement abnormalities on antipsychotics that includes acute dystonia, akathisia, and involuntary movements such as tardive dyskinesia using the Ames scale. The rates have been very low. They're all reported in the individual trials, and they don't seem to be as high as they have been in adults using antipsychotics. Next question, hearing about once daily dosing for lithium just as effective as BID and maybe better for the kidneys, your thoughts? Would you give the full dose at night? And also, what dose do you start blood monitoring? We, in the large trials funded by the government, in the TEAM study, we gave lithium twice a day, morning and evening, and in the COLT study, it was given 3 times a day. The initial starting dose in COLT, which is again what's in the labeling, is if you weigh 30 kilograms or more, you start out on 900 milligrams daily. If you are less than 30 kilograms, you start out on 600 milligrams daily. They recommend after 3 days to increase the dose if it's being tolerated by 300 milligrams. So that would put somebody up to 900 or 1200 milligrams a day, and then get a blood level 1 week after starting on lithium at those doses. So that's when I would start blood monitoring. The next question, how much do you take into account family dysfunction or abuse and trauma in evaluating mood disorders? I think this is a really important question, and part of the psychosocial history we take on every patient is prior trauma and abuse, but also family history of psychiatric disorders, including mood disorder and substance abuse disorder, as that may be both a genetic vulnerability question if the parent has mood disorder or substance use disorder, but also may make it harder for kids to be adherent both to medication dosing and follow-up visits and attending therapy visits. So I think it's very important. If I've got somebody who's only had trauma, like been in a horrible accident or been horribly abused, with no family history of mood or substance use disorder, and no previous set of mood symptoms, and they're presenting with what looks like a mood disorder, I might think about acute stress disorder or PTSD first and treat those. And those are usually treated with trauma-focused CBT. And after treating for trauma, would go back and look to see if there are persistent mood symptoms that then could be treated with an antidepressant. Is saffron showing promise for the treatment of ADHD? I've heard about this but have no true knowledge of the literature, so I'm not going to answer that question except to say saffron is much more expensive than medication for ADHD and not covered by insurance. And I worry about people selling yellow powder on the internet and saying it's saffron to get people to have a natural medication treatment of ADHD. Any suggestions for what to do when a stimulant has been maxed out and is no longer effective? As you know, at least for children and teens with ADHD, for people who are partial responders to a stimulant, both long-acting clonidine and long-acting guanfacine are FDA approved to be given as monotherapy and in conjunction with a stimulant for treatment of ADHD. So if I've got somebody who's, say, on 72 milligrams a day of oros methylphenidate and they're better on their ADHD rating scale, but they're not great, I'll go ahead and add in the FDA-approved long-acting guanfacine or clonidine and titrate up to the maximum dose on that and see what my response is. Regarding clonidine use in children versus adults, why is it sedating and why doesn't it affect blood pressure? Clonidine in all of the registration trials, both as short-acting, which was an NIH trial of tics and ADHD, and in the long-acting format, can reduce blood pressure. It's right in the label and it's in the side effect profile. So it can affect blood pressure, It can be sedating, and so many times when I start long-acting clonidine, I'll start it at bedtime. And as I go up on the dose, so you start at 0.1 at bedtime, see how we're doing. You might then go up to 0.1 BID. If my person is still sleepy, I might actually give them both doses at bedtime rather than splitting the dose to work with that. In general, also, I would say people are sleepy the first few days, and if you can get past that, so I might start on a Friday, so they're drowsy over the weekend and not on a school day. After about a week, the sleepiness tends to accommodate, and kids get better with that. But again, that's why it's important to have that conversation with families and be flexible on when you dose. And I think that's all my questions. I want to thank everybody, first of all, for being such a wonderful audience while we were there in person, but also having all these great questions. I really appreciate it. And I know Dr. Cutler does as well. Thank you for coming to NEI Synapse. Bye.
Thanks for listening. Stay tuned for the next extended Q&A sessions from NEI Synapse, and make sure to subscribe.